I think the first question is the safety, and we've been really encouraged that the safety has been very acceptable and no unexpected signals at all from any of the arms, including the two combination arms. The highest rates of immune-related toxicity seem to be occurring from the tremelimumab monotherapy arm, noting that the tremelimumab monotherapy is given at the high dose of 750 milligrams IV flat dose monthly for 7 doses, and then transitions to Q3 month dosing. And so we know from other studies of historical CTLA-4 inhibition that higher doses of CTLA-4 inhibition are associated certainly with higher rates of immune-related toxicity. And so that was borne out also from this 4-arm study. But the T75 plus D and the T300 plus D, the two combination arms, both had really acceptable rates of the metrics that we track for an HCC study, including serious adverse events, related serious adverse events. And one particular outcome that I'm interested in as a clinician is the requirement for corticosteroids, which, immune-related toxicity that requires systemic steroid use are generally a higher degree of clinical complexity, a higher degree of risk to the patient. And so what we saw from the T300D arm was only around 24% of patients ended up requiring systemic steroids in that 74 patient cohort. And again, that's an encouraging number when we compare it to other combinations of CTLA-4 and PD-1 inhibitors that are also being studied in this context and in other tumor types, which have reported even as high as 50% rates of steroid use. So on the safety front, again, the outcomes are reassuring and in fact encouraging in my mind for an acceptable or if not favorable toxicity profile for a CTLA-4 combination. And turning towards the efficacy, the other question that you are alluding to in terms of the adoption of this regimen, I think always must use caution when interpreting an open label phase 2 study. The sample sizes, I think, in each arm are pretty robust, and the fact that we saw very similar outcomes when looking at each arm, each part 2 and part 3, and overall, the numbers are tracking along quite similarly between cohorts, so that also reassures. But in terms of adoption, tremelimumab is not yet labeled for HCC, so this isn't a regimen that would be available prior to an FDA approval, but I think that it really augments the level of interest in the Himalaya trial. The Himalaya trial is a randomized phase 3 registrational trial of the combination and has 3 arms currently after an amendment. So the 3 relevant arms in Himalaya are the T300 plus D combination arm, the durvalumab monotherapy arm, and the standard therapy control arm of sorafenib. Himalaya has completed accrual, and we're looking forward to seeing results in the not too distant future.